Good evening, Tom Davis here with Sagis Diagnostics. Very glad to have everybody joining us either live or in a recorded session. Today, we're privileged to hear from Dr. Tyler Enos. Tyler is boarded in dermatology and is currently completing a Dermpath fellowship in Houston. He'll be going into private practice as when he finishes moving to Amarillo. Tyler did his training at UT Southwestern. He's an excellent teacher, and he'll be talking to us about granulomatous dermatitis. If you have any questions at all, please feel free to email us at education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. So without any further hesitation, I'll turn the floor over to Tyler. Tyler?
Hi, welcome. I really want to thank Dr. Davis for allowing me to go run through these slides with you. I think you'll really get a lot out of the session, regardless if you've reviewed them previously or if you're just going through them live with me. We'll go ahead and get started. I'm going to try to, I know the video quality is not going to be exactly perfect here, but I'll try to stop my video to increase that. Before we get started, I want to cover a few things about histiocytic inflammation or granulomatous inflammation. When people try to explain granulomatous dermatitis, it can kind of get confusing for some folks. I think that some people think about granulomatous inflammation just being like nodules or well-circumscribed collections of histiocytes. But what someone says when they're talking about granulomatous dermatitis is really that the histiocytes predominate in the inflammatory infiltrate. So there can be a smattering of other cells, but the histiocytes are kind of what takes charge and what's most noticeable. Pathologists use the term histiocytes and macrophages interchangeably. So you'll see that in the literature, just kind of goes back and forth. So keep that in your mind. One thing that's helpful to me is that many people much smarter than I have written about this topic in the past and kind of have divided these disorders up in different ways. The most helpful one for me is kind of this five-pronged approach when you're looking at inflammatory infiltrate that's predominantly histiocytic. And they're basically divided into 5 categories. So the first one is a sarcoidal granulomatous dermatitis. Those are going to be what you classically think of as like the discrete round or kind of oval collections of epithelioid histiocytes that don't have too much surrounding inflammation. So not too many lymphocytes or other cells throughout them. The next is tuberculoid granulomatous dermatitis. Those are also nodules of histiocytes, but a little bit less well-defined than the perfectly circular sarcoidal granulomas. And usually they're rimmed by lymphocytes or some other inflammatory cells. They can have necrosis, but that's not a requirement. Next is palisading or collagenolytic or necrobiotic. I don't want to anger the Dermpath gods by using some of those terms, but I actually think that necrobiotic can be a useful term for comprehending those. But a palisade is basically just a fence. And so in the skin, when we're looking at biopsies, that just means that there's essentially a palisade, a fence around the material in the dermis. Next is suppurative. Suppurative granulomatous dermatitis is just something that's neutrophil rich. So you'll have many histiocytes, but also neutrophils. In the skin, the most common reason for that is a ruptured cyst or follicle, but there are many other things that can cause it as well. And then lastly is foreign body granulomas. And foreign bodies are a little bit confusing because sometimes you'll have a palisade around the foreign body in the dermis, but those granulomas are marked by foreign body type giant cells. So they have those sort of large cells with abundant cytoplasm and haphazardly arranged nuclei. And I think the big key point when you're thinking about granulomatous dermatitis is to remember that there's really a big overlap in diseases in dermatopathology and in dermatology clinically. And so some of these diseases you'll try to ram into one category and maybe there's an overlap or bleed over into another. And that's okay. If you know the salient features, you'll be able to get to the diagnosis the majority of the time. And then also, I always just like to talk about morphology clinically of these lesions. Most of these diseases will have minimal surface change, and they're really either plaques or nodules. So with that, we'll kind of go ahead and get started on this first case. This is truly a low power diagnosis. So if the resolution is a little bit low quality on these slides, I'm sorry, but that can actually be helpful for granulomatous inflammation. So this one is a punch biopsy. I think at the low power, you can appreciate that there's somewhat of kind of these circular or ring-shaped collections of histiocytes, potentially surrounding something in the dermis here. There's this big swath of lymphocytes here, but the majority are these paler cells that you can see at low power sort of make up these groupings. And so we'll go in at a little bit higher power here and notice that the histiocytes are sort of fenced around this collection in the dermis of degenerating collagen, and it's stained a little bit with a blue or kind of gray hue, and that's mucin. And so this is classic granuloma annulare. I think noticing that there's the palisade at the low power is important. You can even get it here on the 1x. And then as you go in a little bit higher, I think it's more noticeable that it's surrounding this altered collagen here, and then the mucin deposition right in the center. Remember that GA, granuloma annulare, comes in two flavors. This is the classic palisading type, but there's also an interstitial type, which is a little bit more difficult to see because it's basically in your busy dermis differential and can be kind of subtle. And that's where you just have to make the clinical fit with the slide. But this one is granuloma annulare, a classic great example. And I think that one is easier to see on the low power. We can look at this second cut here and notice that here there's that sort of rim again of histiocytes and blue in the center. It's superficial and deep. Lots of granuloma annulare will be like that. There's a deeper form that can be sort of at the deep dermis and subcutis as well. Okay, on to the next slide. Try to get this turned the right way for you. This is also one that I think becomes more, apparent at the low power than if you were to zoom in on 20x right away. And so starting low here, I think that you can also see, again, that situated sort of here in the reticular dermis, there's again a palisade. It might be difficult if you haven't looked at too many slides before to say that this is going to be granulomatous inflammation. You may even think about some sort of tumor, but as you come in a little bit higher, you can again see this sort of walling off, this fencing, palisading of cells. And again, there's degenerated collagen here in the center, but it's more of a magenta or hot pink red color rather than that blue that we were seeing previously. This diagnosis also has a little bit more of that sort of busy dermis differential or somewhat fibrotic dermis, and the histiocytes can be a little bit interstitial as well. Just kind of highlighting that there. But that deep red color is fibrin, and it's very common for this diagnosis, common on the elbows, knees. Here's that nice palisade of histiocytes, and then the degenerated collagen here in the center. And so as opposed to the blue hue that we were seeing previously in granuloma annulare, this diagnosis, rheumatoid nodule, has that red color. And it contrasts nicely with GA that way. These are generally in the deep subcutis or deep dermis and subcutis as well. You don't generally get these higher up, but there are cases that do that. Sometimes patients with quote unquote rheumatoid nodule won't have rheumatoid arthritis. In that case, we call them pseudo-rheumatoid nodule. And there is some overlap with what they call deep GA, deep granuloma annulare, but this is a really good example of a rheumatoid nodule. We'll go over to another piece here just so you can sort of see. If you only got this cut here, it's a little out of focus, I know. If you only got this cut here, you can still see that there's a nice palisade. Maybe you think about it being a little bit more blue, but taken in context, with this cut here, there's that nice red color for a rheumatoid nodule. So a good palisading granulomatous dermatitis, which is deeply set with a red center. Okay, next case is a small punch biopsy. Context clues in Dermpath are always helpful. And so there's all these small vellus hair follicles here. And so this is actually on the face. So that might limit our differential just a little bit. I'm trying to let this come into focus here, but this is going to fall into a sarcoidal granulomatous dermatitis. There's these kind of superficial and deep, well-circumscribed collections of epithelioid histiocytes. Even at the 2x here, you can notice that there are some giant cells located closer up to the epidermis. But some of these are just so discrete, very, very easy to see the collections. There's always some scattering or some smattering of lymphocytes that are either surrounding the nodules or even contained within them, but not an abundant amount. And I think these here are really, really good examples of what you would call a sarcoidal granulomatous infiltrate. The giant cells here are a little bit more easy to see. Some of them even contain a little bit of hemosiderin. So a sarcoidal granulomatous dermatitis on the face, that's essentially a differential, and the dermatopathologist can help tease out what that's going to be clinically for the patient. But these are the discrete naked granulomas. People say naked because they have few surrounding lymphocytes. And I think the other kicker here is that there's no necrosis within the granulomas themselves. So there's only cells. You don't see any dead necrotic tissue on the inside of them. So this is a sarcoidal granulomatous dermatitis, like we said. This diagnosis is actually cutaneous sarcoidosis. You do need to do bug stains to rule out some infections that can look similarly. Sometimes even a foreign body could cause a sarcoidal granulomatous dermatitis. So it's really a diagnosis of exclusion. Sarcoidosis is in the skin and systemically, as you all know. But the big things are to rule out infection and to rule about a foreign body. So a dermatopathologist would often polarize the slide just to make sure that there's nothing that comes up easily. Although some have described, silica within these granulomas in patients who have sarcoidosis. But this is a great example of a sarcoidal granulomatous dermatitis. And I think you can see that at the low power, it truly is the naked granulomas. Just a minute for this next one to load here. Okay. A little blurry, I'm going to let it come into focus, but I've always liked this diagnosis kind of clinically and histologically. Sometimes it can be a little bit difficult to try to fit it into a category perfectly. And you really have to think in 3D, kind of in the patient's body, what these would look like. I think that at the low power here, let's see if I can go a little higher. At the low power here, you can appreciate that there are sort of some islands of histiocytes, maybe some more impressive inflammation up top, but there are these broad swaths of degenerating collagen, and the infiltrate kind of extends down into the subcutis. The deposits are sort of what they call layered or tiers. And so you could sort of draw a line here for this top one, maybe another one here, maybe another one here. And we'll look at a different cut as well to maybe appreciate that a little bit better. And some examples have better tiering and better layering than others. But I think that you can appreciate the paleness to these cells here. So we're going to be in a granulomatous category. You may not want to commit, to one of our 5 subtypes just yet, but you could think about it being a palisading granulomatous dermatitis. You probably need to go in a little bit higher to let you look at these cells. Okay. I know the resolution's not perfect, but you can tell that these are histiocytes by their abundant cytoplasm, kind of round nucleus. There's one giant cell here. I'm going to come up a little bit higher and see if we can get some more of this inflammation. Most of this, though, is this degenerating collagen, which sort of has a red color to it. Here are some nice giant cells, kind of peppered with lymphocytes. And as we sort of pan through here, there's another cell type that we're looking for, which I know may not come through perfectly on the video. That may be one with the sort of pink edge to the nucleus there. But the cells that we're looking for are plasma cells. And there's some studies that have shown that plasma cells kind of occur more commonly where this dermatitis likes to occur on the body anyway. So it's not entirely clear whether it's driven by the rash or driven specifically by location. But this inflammation, this dermatitis will normally have plasma cells. So we have a somewhat of a palisading granulomatous dermatitis where there are these sort of collections of degenerating collagen surrounded by these larger swaths of granulomatous infiltrate that goes down into the fat. And this is generally on the lower legs. The diagnosis here is Necrobiosis lipoidica. In the past, it was called Necrobiosis lipoidica diabeticorum, so you may still see that name sometimes, or sometimes maybe it'll come up on tests. But they've sort of dropped that naming convention for several reasons. But I think this is a nice example of that. So a deep kind of necrobiotic or collagenylytic, however you want to think about it, granulomatous infiltrate that has these layers, these cake layers. I'm still trying to find plasma cells for you guys. I don't want to. Okay, there's one there. I know it may not come through on the video extremely well. Good. This next specimen looks like possibly an excision specimen. It's very broad. They inked it as well. There's black ink at the edge here. Sort of see that coming up onto the specimen. And again, this one might be one that if you're newer to Dermpath might be tough to commit to saying that this is a granulomatous infiltrate immediately at this low power. But with time, that will become a little bit easier. What I do want you to appreciate, and maybe you can see those giant cells here, sort of surrounded by lymphocytes. What I do want to appreciate, I want you to appreciate here is there's sort of these zones of, let's see, sort of X-shaped necrobiosis or degeneration of the collagen. And you can kind of see them scattered throughout here. Some of the other diseases that we've covered so far can sort of overlap with that, but those zonal areas of necrosis are pretty specific for this disorder. And I hope that at this power, now you can sort of appreciate these multinucleate giant cells. And again, they're sort of alternating with this degenerated collagen and peppered with lymphocytes in here as well. We like to name the giant cells often in Dermpath and in pathology. This is the giant cell that has the wreath of nuclei, sort of foamy, bubbly cytoplasm. Often the edge, the periphery outside of these nuclei will be even a little bit more foamy. Trying to find a good one. But this is a Teuton giant cell, which is commonly described in this entity. And I'm sure most of you have the answer by now, but it's often a periorbital dermatitis and can be associated with paraproteinemias. Try to get you a little higher power look here of some of these nodules. Good. There's some plasma cells in this one. But these plasma cells are also common in this disorder. And this one has good examples of these lymphoid aggregates, which you can commonly see in this disorder. And so if we were going to sum this up on the low power and with what we've seen on higher power, this too would sort of fit into that palisaded granulomatous dermatitis. The palisades here are maybe a little bit more jagged or Z-shaped or N-shaped, which we drew, but this is going to be a palisading granulomatous dermatitis. It's very deep inflammation. You see the lymphoid nodules. And so this is necrobiotic xanthogranuloma. And as we said, it can be associated with paraproteinemias. So that's something that the clinician will need to work up for these patients. But this is a nice example of NXG, necrobiotic xanthogranuloma. Okay, I'll just pan through this next case. This was like also an excision specimen. I think this is the most representative piece. So I'll kind of let you focus in on that and let the computer catch up. There are many hair follicles here, and you can tell that there's a lot of subcutis. This may be like on the forehead or near the scalp somewhere. But the thing that catches your eye at the low power is this really dark pigment. Maybe too dark to be something that's native to the patient. So you can see these sort of globules or sometimes little dots of pigment that are contained in some of these cells, some of these multinucleated cells. Trying to find a good example. Let's see. Go here. I'll let the screen catch up again. Okay. I think this is a good example. You can see the numerous nuclei within the cell, so a multinucleate giant cell that also contains the foreign pigment. And so in skin, when you see this deep, deep black, kind of jet black color, there's really only a couple things that will do that. One is a tattoo, professional or non-professional, and those often will come up in excision specimens or in punch biopsies sometimes. But the other thing is a graphite tattoo or pencil tattoo. So the patient can often remember some trauma that they had there in the past, maybe in grade school or something, where they were stabbed by a pencil or jabbed themselves with a pencil, and you'll get these deposits of this material. And the body sees that as foreign, and these histiocytes are trying to clear it. So these foreign body giant cells often will create a little bit of a palisade. So I think this one is one that kind of bleeds over into multiple categories. And you can see this with any foreign body type reaction. But really it's these giant cells and histiocytes in this large palisade around abundant pigment here that gives this one away. Here's one more zoomed in cut right around here. Good. So foreign body granulomatous dermatitis, here being graphite tattoo. Okay, I'm gonna let the computer catch up here, but this next one will sort of pan through the slides to let you take a look. And again, if you haven't seen a lot of slides, I think it may be difficult to commit to, what these cells are at 2x or 4x. But if we go down a little bit more, I think I just want to get this focused in here for you. I think that it's important to note kind of where the inflammation is. So it's sort of in these discrete collections scattered around the dermis. But then in one area, there's almost a curvilinear or linear collection of these cells. And as we go in a little bit higher, I hope that you can appreciate that they are histiocytes. So abundant pink eosinophilic cytoplasm, kind of centrally placed oval or round nucleus. This one has some lymphocytes, and some of them appear to be a little bit crushed within them. But the important thing to notice here is that there's a structure within the center of this inflammation that is sort of oval with these stringy fibers and sort of wavy nuclei. We'll let that focus in for just a second, but that's a nerve. So we have linear or curvilinear granulomas that are peppered with lymphocytes And then there's this strong perineural predominance. And we can find that in other areas as well. I'll let that focus in for just a second. But again, a collection of histiocytes that's perineural here. This is another nerve sort of cut and cross section coming out at us. And so there is an infection that likes or is neurotropic. So can kind of follow the nerves and is granulomatous, causes a granulomatous dermatitis. And so this one, if we had a phyte stain handy, we would order that, but it wouldn't always be positive. So this one is actually tuberculoid leprosy. So I think at the low power, it's important to note that there are these discrete collections of histiocytes. Some of them are perineural, and I think the clinical history could be helpful to you here if you were given that. But if not, you should be concerned about leprosy, because this is how it inflames the skin when it's more of a tuberculoid leprosy or a lower organism count. And so this is a nice example of that, actually. And you could see how on the patient, this would be like a dermal plaque or dermal nodule. There's no epidermal alteration. It's really just down deep where this inflammation is. Good. That one's very blurry for some reason. Okay, you can see that nerve sort of come into focus here with this granulomatous inflammation. Lepromatous leprosy would look a little bit different. That is when you have a high number of organisms, and a phyte stain would usually be positive. But sometimes these tuberculoid leprosy cases, you won't pick up the organisms even with the phyte stain. Okay. Kind of let you take a look around here. The biggest thing to note right off the bat is that we're sort of on acral skin or near acral skin. It's a acanthodic epithelium, a little bit hypergranular, and then there is a thickened stratum corneum. So that means you're on most likely the hands or feet or near the hands and the feet. So we're sort of panning through here. I think this is our best cut probably. There's this intraepidermal vesicle or intraepidermal pustule here. We'll go in and take a look at exactly what that is. You can see that there's some crusting here. And then many neutrophils and sort of other scattered inflammatory cells within the epidermis here. So this is a pustule. Sort of losing connection here. Hopefully it'll come back in just a moment. Just reload the slide. Okay. And then taken with that, located in the dermis is this large collection of cells. And I think that you can appreciate there's sort of this lighter staining outer portion, and then maybe a more deeply purple or blue inner portion. So we'll go ahead and look at the lighter cells on the outside. And I'll let that focus in here. So taking into account that we're on the hands or the feet, probably there's that pustule up top. And then you see more scattered neutrophils in here, but there are giant cells. And many of these cells that have the larger nuclei are histiocytes. So this is going to be a suppurative granulomatous dermatitis. We mentioned kind of at the top that the most common thing in skin is a ruptured cyst or follicle. The next most common thing is going to be an infectious etiology. So if you have on the hands and feet a suppurative granulomatous dermatitis, you should really be concerned about organisms. In this case has some structures here of these sort of branching fungal elements. So these are hyphae, and you can tell that they have almost like a brown or yellow hue to them. Let's see if I can find some more that come in a little bit sharper. This is a good example here. of these larger caliber sort of branching hyphae. So these they call Phaeohyphomycosis. So this sort of palisaded collection they call a Phaeohyphomycotic cyst. It's caused by Phaeohyphomycosis, and that's just black mold, kind of a dematiaceous fungus that people come into contact with all the time and can cause dermal inflammation, just like this. So I think the big thing is noting that you're dealing with a suppurative granulomatous inflammatory infiltrate, and then you're going on a bug hunt after that. So there are fungal stains that you can do, but for these with the pigmented hyphae, you really don't need a fungal stain. You might do that just to better highlight them, but you can see them definitely just here on the H&E, even with a poor video quality. Good. Okay, the next case. At the low power, I think that you can tell that it's kind of a dense and diffuse infiltrate of a little bit more deeper purple or sort of blue cells. Let's see if this cut may be a little better. Okay. This is the best one to look at. So there's a little bit of normal papillary and upper reticular dermis here, but the majority of the dermis is really filled by these inflammatory cells. So you have this dense and diffuse infiltrate, sort of deeply purple. Even at this power, I think that you can tell these giant cells are starting to come into focus. They're scattered all around. There are many lymphocytes as well, these sort of navy blue, darker, smaller cells. And this is a good example of what we were trying to show on the previous case of a Teuton type giant cell. So it has this rim or wreath of nuclei and this outer bubbly cytoplasm, foamy cytoplasm. So that's a good Teuton type giant cell. And so these histiocytes, if you look at them, they're almost a little bit more foamy, but have this deeper purple color to them. The scattered Teutons often go along with this. And you can have the lymphocytic inflammation as well. I'm trying to come over to the edge here. Good, I think that's a good example of what this is. So this diagnosis is Xanthogranuloma. Sort of name them differently if it's a kid or if it's a child or if it's an adult. And then scattered oftentimes in these, you'll have eosinophils, which you can sort of see here. And here as well. Xanthogranulomas are often just one solitary lesion. If there's more than one, then you can be worried about other things, but usually just one. I think more commonly in children, but we clearly see them in adults pretty often too. And this is a nice example of that. I think noting that there's a granulomatous infiltrate with numerous Teuton type giant cells, these scattered eosinophils as well. And the pattern of inflammation, the dense and diffuse inflammation is really good for a xanthogranuloma. Remember that this is in the non-Langerhans cell histiocytosis family, of which there are many. But a good example here. Great. Okay, next case. And this one may make you think of what you were sort of seeing in the last case. So again, it's like a dense and diffuse infiltrate. It's got that blue hue to it as well when you're looking here at the low power. And it approaches the epidermis, but maybe a little bit of sparing. And the cells are very large. So if I come in here a little bit higher, the individual cells that make up the infiltrate are large. And then there's these smaller sort of peppering lymphocytes. As we come in here on higher power, I think the big thing to note is that there's a little bit of this two-shade or two-toned component to the cytoplasm. So a little bit more deeper purple here, deeper purple or blue. And then on the outer rim here, in this cell, it's a little paler. This one does a good job of sort of highlighting that. And this one here too. And some people, or in some books, or even probably some exams, you'll notice that they use the term ground glass to describe the cytoplasm. I guess I can see that. Sometimes that gets overused and gets, is in a lot of places in medicine. But at this high power view here, you can see, again, numerous eosinophils, these large foamy cells with two-tone cytoplasm. And then I think just remembering that the lymphocytes, EOs, and sometimes you can even have neutrophils scattered out through here, here and here, is common in this diagnosis. There are a couple things that can look this way, but the big thing for the majority of test taking situations, I think that you should know is reticulohistiocytoma, and that's what this diagnosis is. So you can have a solitary reticulohistiocytoma. If there are multiple, then you're concerned about multicentric reticulohistiocytosis, and that can go along with some internal disease, and patients can have awful joint destruction. But if it's just one lesion, it's just solitary. So again, this is a non-Langerhans cell histiocytosis that fits into that family. You'll have the large cells with abundant cytoplasm, sort of two-tone cytoplasm. Scattered eosinophils and neutrophils are common within the tumor. And I think at the low power, you could appreciate that it's a dense and diffuse infiltrate. But this is a great case. Great. We have one more slide that I wanted to review with you guys. Thanks for bearing with me here as the slides load. I'll straighten this one up as well. I know this is very low power, but I just want you to appreciate that it spares the epidermis and papillary dermis. The infiltrate sort of involves the subcutis here. And even at this low power, some more seasoned dermatopathologists could probably make a diagnosis or at least get very, very close to it. The big thing that people always talk about with these is that there's these sort of nodules with darker staining areas and lighter staining areas. And I think that that's pretty evident here. This infiltrate usually will involve the subcutis. So this is a deeper problem. Like we mentioned earlier, this is going to be a nodule or a plaque without surface change. And when we come in and we look at these areas, we see the darker areas here, sort of lighter central area here, and very foamy cytoplasm in some of these cells. There are also scattered neutrophils. And as opposed to the last case where the cells sort of had the two-tone cytoplasm, these are usually either just foamy or some of the other cells have their normal eosinophilic cytoplasm. There's another item we're kind of looking for when you're trying to differentiate these infiltrates. Let's see. Some large plasma cells scattered in here with their perinuclear hop. But we're looking for cells within the cytoplasm of these histiocytes. Trying to find a great example of that. Okay, here, this cell is containing these two lymphocytes in a plasma cell. And that phenomenon is called imperipolesis. So these cells really engulf the lymphocytes in plasma cells. And the studies have shown they're not necessarily in lysosomes, but they sort of pass through these cells. And you can see them within the cytoplasm. Try to find another example as well. I know that these cells sort of bleed into one another, and so it can be a little bit difficult to tell, but you can tell here that this neutrophil is within this cell. So that's peripolesis. Let's see if we can find a better plasma cell or lymphocyte. Okay, I think we've seen a couple examples. But this disease is called Rosai-Dorfman, also in the non-Langerhans cell histiocytosis family, but will often have the peripolesis, and these tumor cells will be CD68 positive and S100 positive. And that's something that you'll need to know going forward. But a nice example of that here. I want to thank you guys. I hope you got something out of the video. I know that the quality may be lacking just a little bit, but granulomatous dermatitis is always interesting. And I think the low power is so important if you can try to fit it into one of those categories. Just appreciate that granulomatous processes can be inflammatory or neoplastic, and always keep the clinical in mind. Thank you.